Thanks very much. I know there are a number of people standing and a couple on the floor. There are a few seats scattered in, so if you want to be a little more comfortable, feel free, and I'm sure your neighbors will be happy to let you squeeze in between them. So, all right, so my topic over the next few minutes is around this area of who should get something different than R-CHOP for diffuse large B-cell lymphoma. These are my disclosures. So as we've talked about, and as this audience knows, because this is the most common subtype of lymphoma, most patients with large cell lymphoma present with advanced stage disease. Our goal is to cure them. About 70% of people can be cured. We have good clinical prognostic tools. Our standard for most patients is R-CHOP. Clearly, we'd like to cure more patients, move that cure rate up to 90 or 100%, and we'd like to reduce the toxicity for those who do receive R-CHOP, which obviously is manageable for many, but for some is too much, and obviously would be nice to be easier for everyone. So the question really is, who do we treat differently? Because if patients are refractory to second-line therapy, the prognosis is poor. And I think this is different from Hodgkin lymphoma, where in Hodgkin lymphoma, if you relapse or don't respond or really relapse to upfront Hodgkin lymphoma therapy, you still have a pretty good chance of cure. However, in diffuse large B-cell lymphoma, if you don't respond or you relapse to your first-line therapy, your chance of cure is much lower. And that's summarized on this slide, where we typically use R-CHOP, a few occasions dose-adjusted R-EPOCH. You go on to get a second-line therapy. If you relapse, one of a dealer's choice that are just about the same is listed on the right. If you're transplant eligible and you respond to your second-line therapy, you go on to get a transplant, but ultimately a minority of those patients are cured. And so we have a large number of patients, a meaningful number of patients. If you think that this is the most common lymphoma, there are more cases of relapsed large cell lymphoma than there are of mantle cell altogether. So it's almost a disease entity in and of itself to tackle in our discussions and in our patient populations. And so clearly this moves very quickly from being a highly curable situation to a sometimes curable situation, but usually not, to a much more dismal outlook. And we heard a lot about CAR T cells and other novel treatments. You'll hear in the next talk from Sven DeVoe about new things coming along for the relapse setting, but this is really focused on, is there anyone as of today where we should do something different than R-CHOP to try to move things to the left of this algorithm as best as possible. And I'll just remind you of dose-adjusted R-EPOCH and the differences, because we'll touch on it a little bit later. I'm sure Ann Lacase in the primary mediastinal situation will talk more about that, but dose-adjusted R-EPOCH is infusional, adds etoposide, and adjusts doses up and down with each cycle. And that's been one area of investigation that we'll come up to. But just to remind you that just because we know that we have a problem doesn't mean we have a solution. And this has been evident by the IPI that's been around for over 20 years, almost 25 years, and it's not so hard to tell who's going to do better and who's going to do worse based on the IPI risk factors summarized here. The problem is that we don't know as of today, should we treat a patient differently if they are low risk or high risk? And I would venture to say that the data today suggests that whether or not you have low-risk large cell lymphoma or high-risk large cell lymphoma by these parameters, putting other issues aside, it doesn't really matter knowing that. I mean, you feel less good or more good, but at the end of the day, your treatment is really the same as of today if you're going based on this very robust clinical prognostic score. So what do I want to know when I see a new large cell lymphoma patient? I do want to know the International Prognostic Index. That gets me thinking a little bit more about their expected outcome, although that in and of itself doesn't change therapy. I think about primary mediastinal lymphoma, which we'll come to later. There's a whole discussion around that, and I won't focus on that in this talk. I want to know if the patient has CNS involvement or testicular involvement or risk factors for CNS involvement, and we'll come back to that in a minute as to how that might change my therapy. I want to know if the patient has bone marrow involvement for the same reasons, although I think that the utility of bone marrow assessment in more and more clinical situations, particularly with PET scanning, is becoming less and less relevant. Mostly I want to know, does this patient have double hit large cell lymphoma or double protein expressor, although I would say that the double hit is clinically relevant. The double protein, despite the fact that it says R-EPOCH next to it, that is not necessarily what I would choose for that population. But the point being that I would think about those parameters because it may change our therapy, if not now, in the near future. And I want to know the cell of origin, although again, as of now, we don't know that cell of origin changes things. So some of this pathology is of kind of human interest, and some of it is practical interest of I'm going to do something differently based on the result that I get. And a lot of this is just I'm going to worry more or less, but I don't know that I have a solution for the problem if the patient is likely to have a problem. And so this is a summary of patients where I would think about using something different than R-CHOP, and we'll talk about these different scenarios over the next few minutes very briefly. Double hit, yes, I would do something different. Double protein, no, I would not do something different as of today. Primary mediastinal, HIV-associated, testicular, limited stage, CNS involvement, and elderly patients, and we'll get into the definition of that in a few minutes. I think that those are scenarios where I would think hard and often use something a little different than the standard run-of-the-mill R-CHOP times 6 cycles. So the double hit versus double protein is an important distinction to make, and the terms can be confusing. I think there's more and more clarity around these two entities. Double hit lymphoma has had a variety of different names, but it is virtually always a germinal center subtype of diffuse large B-cell lymphoma, and the key is that it has translocations of MYC as well as BCL2, BCL6, or both, in which case it would be triple hit, but these are FISH, fluorescence in situ hybridization, diagnosed entities or specified entities. On the other hand, double expressing lymphomas, which are based on protein expression and therefore immunohistochemistry generally, those entities or that entity is defined by double expression of the MYC protein and BCL2 protein, and the percentages there are, I think, suggested, although there's some variation here as to the number of positive cells to call something a positive double expressor or single expressor. These tend to be activated B-cell subtype and probably are why the activated B-cell subtype of large cell lymphoma do less well, and these are kind of intermediate. They do less well than other kind of run-of-the-mill diffuse large B-cell lymphomas, but not as poor as the double hit. So these are two entities that I think if you're seeing large cell lymphoma patients, you need to routinely think about, does your patient have this? You need to understand the difference between the two, because if not now, in the near future, for at least one of these scenarios, if not both, before long, we may be doing something different. So before we go too far with this, I think it is fair to say that we need to be a little bit careful in defining outcomes and defining best therapies for double hit and double protein patients, because virtually all of these both of these are associated with less favorable outcomes based on the clinical features. So the IPI high-risk patients and higher-risk patients tend to be double hit and double protein. So do they do less well because of their IPI status, or do they do less well because they're double hit or double protein? These are generally series of patients, often single institution. They tend to be retrospective series, so there are selection biases that could figure into this one way or another. The molecular testing to define these in various studies in the literature are quite variable. I would say that the pathologists and the morphologists are not always on the same page as to what is or is not a double protein expressor in particular. And again, the nature of these studies, these patients were often treated across multi-centers with different drugs for different reasons, and then trying to say, well, one is better than another when you could have picked that therapy based on a variety of different features makes you be careful, or should make you be careful about drawing conclusions, because they're not prospective randomized trials. So this is just one study looking at double hit large cell lymphoma. And you can see the non-double hit does better, the yellow in both curves, for overall and progression-free survival, whereas the double hit patients did less well. So that argues that this is a less favorable subset when you treat it with R-CHOP. There are a couple different series. These are two of them from different groups, suggesting that the patients treated with R-CHOP, again, do fairly poorly, and that treating this with something more aggressive, whether it be R-hyper-CVAD or more commonly dose-adjusted R-EPOCH, seems to be associated with, and again, these are not randomized trials, but retrospective series, tend to be associated with a better outcome if they are treated with something other than R-CHOP. And so dose-adjusted R-EPOCH is what we tend to use for our double-hit lymphoma patients. There is also some discussion around the value or lack thereof of consolidation with transplant, and I don't have a slide on that, but there have been a few different data sets suggesting that consolidation is, if you went into a CR, consolidation is not really needed with an auto transplant, meaning doesn't have value, although I would say the same biases figure into those studies as well, because you have to figure that the reasons for transplanting or not transplanting somebody in a non-randomized trial may be different, i.e. the worst patients that you worried more about got transplanted, the better patients that you worried less about didn't get transplanted, and therefore the outcomes were similar, but they were really different patient populations. So I think we have to be careful about taking that too far, but nonetheless, I think that's a legitimate conclusion at this point. So at this point, it's important to note that we are in the cooperative groups in the U.S. planning a study looking at, and Dr. Rutherford is leading, along with Jeremy Abramson at Mass General, a study, a phase 1 trial of dose-adjusted R-EPOCH plus venetoclax, the BCL2 inhibitor. That's an ongoing phase 1 trial that is proceeding well, suggesting that we can give venetoclax with dose-adjusted R-EPOCH. And that is ultimately, we expect, going to lead to a randomized trial where we will be adding venetoclax to, in the double hit group, dose-adjusted R-EPOCH, and in the double expressor group, R-CHOP. And so we look forward to trying to improve these outcomes based on a targeted therapy directed against the BCL2 protein. So many of you, if we had asked this question a year ago as to who should get something other than R-CHOP, a number of people, I think, would have, in more cases or in some cases, beyond what I've said, used dose-adjusted R-EPOCH. And so we now have some randomized data on this, and this was presented by Nancy Bartlett at the ASH meeting last year, taking untreated large cell lymphoma patients, looking at R-CHOP and dose-adjusted R-EPOCH. These are the patients on the study. You can see that they were reasonably typical, although perhaps slightly more favorable in risk, with about 2/3 of patients having IPI 0 to 2. As you would expect, dose-adjusted R-EPOCH was more complicated, a bit more toxic, partly by design because of the dose escalation. And in fact, the outcomes were the same. And as we look at this, we have analyses going on in the double hit group. We have analyses going on in the double expressor group. I would say as of today, we don't know that we should treat either double hit or double expressor based on these data any differently. But again, I still hold my prior comments around the double hit group, and we'll see data with double expressors as they come along. But again, these are complicated analysis, and keeping in mind that this is a relatively favorable subgroup of patients or population of patients based on the demographics, which means we're probably not going to have huge numbers of double hit and double expressors to draw robust conclusions. So as of now, I treat patients that are double hit with dose-adjusted R-EPOCH based on the earlier data, and patients with double expressor I treat with R-CHOP. And I think that's our most robust data at this point in time. So now I want to talk about a couple other clinical scenarios that we might think about doing something else, and just kind of a rapid fire, a few different things that you'll encounter in your practice. This may be something that you occasionally see, a patient with large cell lymphoma and testicular involvement, and you can see some data from an Italian group looking at, in a phase 2 fashion, patients with testicular large cell lymphoma that were treated with R-CHOP, and based on stage went on to get testicular radiation or involved field radiation if they were stage 2. So the message there is that you need testicular radiation to the contralateral testicle if you've got testicular involvement, and there is a risk of central nervous system involvement. And in this study, they used intrathecal methotrexate. So I think these are the data this is the regimen that has been most widely and prospectively studied. And the outcomes here you can see are pretty reasonable, with about a 75% cure rate. You also see that the cumulative incidence of CNS recurrence was relatively low, but still meaningful. The 5-year CNS cumulative incidence was about 6% or so. So again, not high, but not zero either. And I think it still calls into question, did the intrathecal methotrexate help or not? And that's a question that comes up a lot. What's the value of intrathecal methotrexate in patients with CNS involvement risk? But this is how I would generally, based on these data, treat a patient with testicular large cell lymphoma. What about limited large cell lymphoma? And I think this accounts for about 10 to 20% of patients with large cell lymphoma. I think the most robust data with follow-up are the SWOG data looking at R-CHOP for 3 cycles and involved field radiation. You see that the 5-year follow-up shows a pretty good outcome, 2-year estimates and 4-year estimates, I should say, being around 90% or so with progression-free survival. So this would seem to be pretty favorable. This would call into question, and Laurie Sen has presented this kind of a series of care. I don't know that I would quite call it a prospective trial, but this is a population-based study looking at a plan or a guideline to treat patients in this fashion, where after 3 cycles of R-CHOP, if you were PET negative, you did not get radiation. If you were PET positive, you did. And at least the data that we've seen on this so far suggests that if you're PET negative, you do pretty well without radiation. If you're PET positive, a 3-year time to progression with radiation is 60%. So I would say not fabulous for limited stage disease. And so the question is, can we improve upon that one way or another? And there are studies looking at that as well. And I think this was an interesting study presented led by the SWOG group, looking at some of the early SWOG data going back to studies started in the late 1980s, looking at CHOP and involved field radiation versus CHOP times 8, treated like advanced stage disease. Obviously no rituximab here, but the suggestion that for whatever reason, with long-term follow-up, these limited stage large cell patients can have very late relapses, even occurring 10, 15, 20 years out. So, why is this? Would it be different if you included rituximab? We typically think with large cell lymphoma, you're in pretty good shape if you haven't relapsed within a couple of years. Is this a different disease? How are these patients relapsing? A lot of interesting questions. So I think we don't have a clear consensus as to how to treat large cell lymphoma that's of limited stage, but I think in most situations it may be reasonable to leave out radiation if the patient is PET negative. But again, the level of evidence for this data, I think, is moderate at best. So what about CNS involvement? That's a common question that comes up. You're seeing a patient, you think they have high-risk disease high risk for CNS relapse. What should you do differently in that patient? First of all, who is at high risk for relapse? So this is the CNS IPI suggesting who is most likely to have a CNS relapse in large cell lymphoma. And it turns out that the biggest risk factor is having kidney or adrenal gland involvement of your large cell lymphoma, where you can see in the upper panel that the risk of CNS relapse, if you have kidney or adrenal involvement, is in the range of about 15%, so pretty meaningful, I would say. The other risk factors seem to be less powerful, but they include basically the rest of the IPI risk factors. So if you have high-risk IPI disease, you have high risk for CNS relapse. But in particular, if you've got, again, kidney or adrenal gland involvement, that would make you particularly at high risk. So then the question is, what do you do about it? Does intrathecal methotrexate work? Is it worth doing? It's a hassle. People get post-LP headaches, et cetera. And I think that remains an open question, whether or not intrathecal therapy is effective at preventing CNS relapse. We have some indirect evidence around that, but it's, again, I would say relatively moderate in its level of evidence. If I am particularly worried about a patient for CNS recurrence, I tend to use the R-CHOP with day 14 methotrexate. This is based on data from Jeremy Abramson, which is basically a series of patients treated with high risk at the time. Important to keep in mind at the time. You can see their risk factors here. A lot of them had bone marrow involvement, sinus involvement, some renal, adrenal, some liver, and epidural involvement, and basically suggesting that giving 3 or 4 cycles, and this was done, it was wasn't a prospective study. It was a compilation of patients treated this way, suggesting that about 70% of people were cured, given the fact that they had high-risk disease, and did well with a risk of CNS recurrence, 2 out of 65. So again, a reasonably low CNS recurrence rate with this approach. Now, this can cause problems if the patient's elderly, has renal failure, et cetera, or if you're using dose-adjusted or EPOC, giving mid-cycle methotrexate is occasionally attempted, not usually or always successful, at least, but sometimes. So, but I tend to use and our group tends to use the mid-cycle or the day 14 methotrexate or 15 methotrexate, which is usually manageable for the majority of patients. A word to our mini CHOP, and this is this not rare scenario of a patient over the age of 80, and this is based on data from the French group largely, which essentially took our CHOP and reduced cyclophosphamide, reduced doxorubicin, reduced vincristine, reduced prednisone, so more or less half doses of several drugs, and said, well, let's give this to 80-year-olds. And you can see, and I'm not showing you the toxicity data, but it was, I would say, reasonably well tolerated in this patient population, probably better, certainly better than full dose R-CHOP would be, I would say. And that based on the functional status of the patients, but even with relatively poor functional status, somewhere around 50% of patients had an overall survival of 2 years or longer, and so I tend to quote these patients a cure rate of somewhere around 40 or 50%, which is, again, for an 80-year-old who often has an unfavorable lymphoma, fairly reasonable. And obviously, we're balancing out efficacy and toxicity in this scenario. So just to wrap up, I just want to highlight that there are a lot of new approaches in large cell lymphoma that are not yet ready for prime time. I'm sure Sven will tell you a little bit about these new drugs, and there's a lot of early studies ongoing, phase 2 studies ongoing, whether it's using independent of cell of origin, treating all comers, or treating patients specifically based on cell of origin. We've been very interested in azacitidine in R-CHOP. You heard from Ari Melnick earlier about epigenetic approaches, and there are lots of reasons why azacitidine may make sense in association with R-CHOP that have been generated by Leandro Ciochetti, who moderated this early session, and Peter Martin and others have been looking at azacitidine and R-CHOP in clinical trials, and we'll be presenting some data later this year that I think are quite promising for the use of azacitidine and SMAD1, which is in some way functions as kind of a tumor suppressor, maybe a biomarker for those who may be likely to benefit. And so I think we're going to hear more about this approach, but again, not yet ready for prime time. You've heard about and know about the ABC and GCB subsets of large cell lymphoma, lots of pathways, and the idea that the Germinal Center and ABC subsets do differently in these retrospective trials. Lots of pathways we could go after in both the GCB and ABC, and you've heard about some of these pathways earlier. You'll hear about some of them, no doubt, from Sven in a few minutes. And so the concept of moving toward subsetting large cell lymphoma and treating patients differently based on which subset the patient falls into and drugs that target the subset, I think is quite promising. I think outside of protocols, people ask all the time, should I give lenalidomide with R-CHOP? Should I give ibrutinib with R-CHOP? And those trials are ongoing. I would say that the jury still needs to be is still out there, and I have not routinely in practice used those approaches even in higher risk patients. And so I think those are drugs that add toxicity, no doubt, and I think we need the randomized trials. Some of these drugs, again, bortezomib, we've had negative trials, and we have ongoing trials with ibrutinib and lenalidomide. And I'll just point out that while this is the relapse setting, we do have an ongoing intergroup trial looking at ABC subtype relapse large cell lymphoma, not the topic of this talk, but I want to plug this cooperative group study that is taking ABC subtype large cell lymphoma patients. They get centrally determined to be ABC by the nanostring assay and then randomized to ibrutinib plus a transplant versus a standard transplant. And I think this is an important trial for this sort of approach. And I think the challenge of why we can't jump to this, we've alluded to earlier in our discussions today as I wrap up. The idea that the the retrospective studies show these big differences in outcome based on cell of origin, but the prospective studies, one reflected on the right, is that basically showing that, and this happens to be a study of R-CHOP and bortezomib R-CHOP with no real difference, but that R-CHOP in a prospective study for non-GCB subtype patients seems to do pretty well. And that's because of the fact that, again, we have selection biases that go into, that are not evident in our retrospective analyses, but are evident in our prospective studies, and therefore, when we go on and do the prospective study of the new drug with R-CHOP, it is not clear that we have the same population and end up excluding intentionally or unintentionally, I think the latter predominantly, the patients who are sickest and most likely to benefit from the new treatment. So my last slide, I think that we have lots of targets, and again, you'll hear more about them no doubt in the next talk, but it is not necessarily a slam dunk that adding them to R-CHOP is going to improve things, because again, these drugs may not be as good as we think, although we hope so. We may not be able to subset the patients as well as we like. We have the patient selection issues, and so I think it highlights that we need to continue to develop innovative study designs, better drugs, better biomarkers, and most importantly, have control groups in these trials so that we can make most robust comparisons. Thank you very much.